My second part, if I have time, 10 minutes?
10 minutes.
Okay, nice. So the second part will be about some factors, but before them, do you know that something is wrong there is no technician, I think, so all of us are dentists. We usually putting ourselves, either we know it or don't know it, we are putting ourselves higher than the technician, which is wrong. First of all, if you are higher and greater and bigger, why you are working with a technician? Do it by yourself. This is the first one. The second one, some point is you are the person that's in charge or the person that's responsible for the decision, to make a decision. In some other points, you have to communicate together. In the others, the laboratory should tell you about it. They have to help you. So it does not mean I'm better than laboratory. It is a teamwork, like the orthodontist, the periodontist, everyone. So the communication between all of them should be very good, but dentist, restorative dentist, is responsible to make a joining of the links. So that was the chart of the steps. What I should suspect and what I should respect of my patient. First of all, goals of the patient. The patient may asking you to improve her problem, but the issue is not, it could not be improved by the veneers, by indirect veneer. You know, you have 4 points to play with it: color, shape, size, position. Position, if it's minor, sometimes could be. But the others, it could be mainly with the direct or indirect veneers. But the goals of the patient should be realistic, and they should make a coordination with what? With her case or his case. So I have to know about the goals of the patient and also the type of the patient. I think in two different seminars I explained the different type of the patient, but briefly, one of them, we have also a little dentist here. One of them is the patient that's like, they just like a dove. They are respecting everything. The second one, they are just like the bulb. So I have to know my patient before my case, because patient is different, as we know. Patient management also is different. The second point is the midline position and count of the occlusal plane. This is the benefit of the DSD, or the two horizontal lines if you put between two eye pupil and compare with the horizontal plane, so as to know that is there is count or not. I usually simplify the using of the DSD in my lectures. I say that you can use also PowerPoint, and then as we explain it, lip position and fullness. We know that thicker lips can give you a chance to have a more conservative treatment planning, because you can add and the lip can overlap it and can envelop it without problem. So fullness and position. Display, I don't want to talk more about it. This is the nightmare. Occlusion, confusion. I lectured one seminar in Nova about occlusion. I wish I could do the second one, because it's advanced about occlusion. Occlusion is the base of, I think, in dentistry, and you have to respect it of the occlusion, especially the anterior guidance, as we say, is the keystone of our dental work. If you see here, desire tooth contour also with the occlusion, combine it. Sometime, one of the guys showed me right now before the lunch, he said that I have this case has a space, but the lower canine was not allow us to have to fill the space in between the upper lateral incisor and the upper mesial surface of the upper canine. So you have to respect also, even the contour should be correlated with the occlusion, and occlusion is just like the Gary Bush Sari here. Everything is coming to the occlusion. If you see this one of my cases, I was checking the occlusion of the case, and if you see anterior guidance, canine guidance, and right and also left. And you have to structurally, if you see here, many of it, of course, you are with the Miller forceps putting what, doctor? Yes, I put the So I'm checking also the contacts if there is any premature contact and if there is any structural defect. All of them should be checked, and then I can go for the next step, which is the incisal edge position. Incisal edge position is highly related to the lip, in the upper lip position, and also in the lower teeth. I should have respect in the upper first of all, and also lower, because we know at 30 years old, we have to have about 3 mm of incisal display for the male, and 3 mm for the females. So when I fixed the incisal display, I should correlate with the lower one because of the overjet and overbite. They are important. As we know, that's the overjet and overbite. For example, overbite is about 3 mm, and overjet is about 2 mm. They should be respected. The canine one also, I have to have 0.5 mm between the upper and lower canine space to 1 mm to have a movement, because the canine is also important. Then, I think it's the final one. I present it quickly because I know that you are tired. So the color will be one of the most important points in the treatment planning. If you are going, I have many cases in the indirect veneer. Dr. Handreni Ziatrim Hana. Many cases I'm managing. Please, don't underestimate in the managing spending time with the treatment planning. Treatment planning is the base of everything. So let the patient talk about my friend, he's the Dr. Handreni's patient. He did a good job. He is satisfied with the work. And I want the same color. It is his wishes. I have scales. For example, my last case, this is I shared it in the YouTube. I have my canal, you can Zardasht and Bradosti. So I asked the patient, what do you want? She said, I want the whitest one. How can I control the whitest one? One of the references on the book of the cosmetic dentistry say that the sclera of the eye, the whitest of the eye, is the scale of the end point of the whitish teeth color. I can in this way guide my patient that your teeth could be whiter than your skin. There is no relation to it. But we have the end point. I will help you. I'm suggesting you to have this color according to my idea. But you are working for yourself. So this is the end point. According to the Arcangelo et al. 2018, he said, yesterday I have seen it has been published, three important in the compendium dentistry. Three important factors should be taken in account before getting started, before touching. Usually the beginners are in hurry to go in touching the tooth. But you have to think about the insertion pathway of the veneer. How many pathway of the insertion we have? Who can help me? Three paths of insertion, 2 paths of insertion, 4 paths. We have 2 paths of insertions. The first one are the buccal one. And the second one are from the up, the vertical one. I have to think about the undercuts conservation of the enamel, because the enamel is my father in the tooth structure. It protects my work. It gives the long life. So I should respect also which one is better for the preserving of enamel, buccal up pathway or vertical pathway. And this will guide you for the preparation. Then, tooth substrate. It is too much dark, whitish, yellow. If it is too much white, for example, each color, if you want to change, you have to give. This is from Ghalib Gurel. Nowadays, the improving of the techniques has been improved more. I mean that you can. For example, here, if you want to change the color from A1 to B1, let's say, a whiter one or stay the same color, you have to give a space of 0.3 millim. Why? Because you are reducting, so the underlying tooth structure is yellowish more. So,
Dr. Zardosh, sorry.
how many?
We have about 3 minutes. We will make it 5. It's very interesting.
Thank you.
I can see that everybody is into it.
You giving me time more?
Yes, sure.
Thank you. I'm kissing your hand.
Astaghfirullah.
Sorry. So the A1 to B1, let's say that is really, you have to increase. You are giving for example, 0.3 millim. Nowadays, you can give 0.2 millim according to your skills and your technician skills and the kind of the cements, because the improvements has changed a lot of the rules. So A2 to, if you have A2 want to change to A1, 0.5 millim of tooth should be reducted. If A4 to A1, it is really 0.9 millim, it's too much. But how can I control it? Of course, ultra-conservative dentistry, like the bleaching before, like the composite for the black surfaces, something which is, you can't play with them. It is important for you, you think before the changing of the color. The final thing is that, ask the patient, please, for the sake of your enamel, for the sake of the long life, reduce on your mind on the wishes of the color improving. You want B1, let me do it A1 for you, B2 for you, A2 for you, because I can't give a space. This is better for you if you want, if you are thinking a long shelf life processes. If they insist, you are scientifically allowed, go on. So, from the beginning, type of the patient, and then the patient's goal, wishes, coming down to the lip, midline, facial structure, intraorally dental structure, and then correlate all of together and make a conclusion to your, write down it. Believe me, sometime I'm putting a small paper on my dental chair stand. When I'm working it, I'm looking back of my, now I'm keep going on this path, on this way, just to, because sometimes I'm forgetting. One of my cases I shared in the KYD group, Kurdistan Young Dentist group, I shared and asked you why I didn't elevate the level of the central incisor. Fortunately, I didn't elevate. But do you know what was the answer? Many of the nice answers I have read, but the real answer was that I forgot. I forgot to balance that soft tissue in between them. So I have to have a chart. I'm not the angel. I'm human. The human will forget about something. So you have to correlate yourself with something just like the consent or something like that to write a lot about it. So I can have just like that, in my cases, how will be the axial inclination, the soft tissue and the pointers, interdental papilla, soft tissue, hard tissue, and tell the patient that this will be your last work. And the conclusion was that I concluded. For my next activity will be that in the indirect veneer, a preparation tour, I invited you to attend my seminar because I will give you many tricks in the preparation, the kind of the preparation and the outline overall. Then specifically, if they're giving me a lot of time, I will give the participant a lot of information. And I have also a course about the aesthetic and restorative dentistry. Finally, with the cooperation of VANEST, with the help of the VANEST, one of my seminars as an article has been submitted in one of the great international European dental meeting at October, inshallah. My article has been accepted with the help of the VANEST company. It will be about the ultra-conservative approach, microscopic ultra-conservative approach of indirect veneer. Nothing I have to say, only I highly appreciate your kind listening and cooperation to present my seminar. Thank you.
Thank you very much. Thank you, Dr. Zardosh, really for excellent presentation. I could see everybody was just into it. That's why we didn't want to interrupt you. Thank you.
Thank
It
you,
was
Doctor.
excellent. Thank you.
you.
And now, if there is any questions for Dr. Zardash, please.